Thank you very much. We'll continue the program with Dr. Mary Kwon. Dr. Kwon is cardiac surgeon at UCLA, and he's going to present on prevention of paraplegia during endovascular repair of aortic pathology. Dr. Kwon is an assistant clinical professor at our institution. Mary?
Okay. Good morning, everybody. My name is Murray Kwon. I'm one of the cardiac surgeons here, and I will be discussing the somewhat tedious but very critical topic of spinal cord protection during endovascular surgery. This is a very vexing issue that was apparent from the earliest days of aortic surgery, even dating back over 100 years ago by Dr. Alexis Carrel, Nobel Prize winner, who recognized that the main danger of aortic surgery is not with the aorta of the heart itself, but really with the nervous system. So just very briefly, as you all are probably reminiscent of from your medical school, the anatomy of the spinal cord perfusion comes off of the posterior wall of the aorta, particularly in the region from T8 down to L2, which is one of the reasons we often reimplant this area. But these posterior intercostal and lumbar branches then go on and give the artery adamcoitus in that area that then perfuse the spinal cord through the anterior spinal artery. So any sort of compromise of that in either open or endovascular repair compromises the blood flow to the spinal cord. The spinal cord also gets collateral supply from the subclavian artery as well as the hypogastric. So that's another reason that we tend to see patients who have had previous operations, whether it's an infrarenal aneurysm repair or some sort of repair up in the arch or subclavian artery, these collaterals can be affected, are at higher risk for paralysis or spinal cord injury. So this is a very busy slide, I apologize, but I just want to give you sort of the historical perspective, and a lot of this has already been touched on earlier, but to know where we are now, it's helpful to know what we were dealing with. And in open surgery, some of the earlier large series had already delineated a paraplegia rate, particularly in the extent 2. These are the longest extent from subclavian down to the bifurcation, and that makes sense. But even within the other lesser extensive aneurysmal pathologies, you were still seeing a certain amount of paraplegia, and this was over 1,000 patients. When Dr. Coselli re-looked at his next series of data in a more modern era, he divided them into both immediate and delayed. And you could see that there was still some differentiation. There is differentiation now between many of these open repairs are occurring at later time points. So they're not necessarily perioperative, but they occurred in the 48 hours after the operation. So typically, these patients would move their extremities right after and then go on to develop some sort of spinal cord issue. And the other sort of notable finding in his series was that many of these patients actually recovered. So the permanent spinal cord paralysis had diminished. So in his summary, he found that in his earlier series, about 37 or a third of his patients had a spinal cord deficits noted in the delayed period. And in his later series, it was a much higher proportion. So why is this? Well, then the logical explanation would be improved perioperative techniques that allow spinal cord perfusion. So now the major liability was occurring after the surgery itself and how we manage these patients in the intensive care unit. So this has all been sort of addressed earlier very well. I don't want to belabor them, but in open surgery, the things we do are to limit the ischemic time, so reducing the cross-clamp times, the concept of sequential clamping of the aorta, to limit the time that any individual segment may be subjected to hypoperfusion. The idea of reimplanting critical areas, like I said, the T8 to L2 area, and then usage of hypothermia, whether it's profound. Now, deep hypothermic circulatory arrest is not a concept that's germane to endovascular surgery, but hypothermia as a spinal cord protection was utilized. perfusion of the spinal cord, so blood pressure minus the pressure in the spinal canal, CSF, is the perfusion of the spinal cord. So things that elevated the perfusion pressure, in other words, elevating the MAP and lowering the resistance in the cerebral spinal fluid, were protective measures, so the CSF drain. And then measures to detect early on, so somatosensory evoked potentials, etc., to detect early and potentially make some manipulations that would help the patient, would move this curve out. So if you look at the aortic cross clamp time, and in a warm patient, you can see that there's near universal spinal cord injury at around 45 minutes if you did none of the protective measures. But with a combination of cooling as well as cerebral CSF drainage, you can get this curve to move out, and the patients can tolerate a 40-minute cross-clamp time fairly well in this model. So what do you think are the differences now that we're in the endovascular era? And so on the one hand, you would say, okay, so in endovascular surgery, you don't need a clamp. Okay? You avoid the need for reducing or removing pulsatile flow because we're not using bypass, either full cardiopulmonary bypass or left heart bypass. So things should be better, but on the other hand, you're often covering increased zones of the aorta to effectuate your coverage. So you may be increasing a larger length, and you may be compromising intercostals that you have no way of reimplanting in the endovascular. And then there's embolic complications with the wire, the sheath, the device itself that could also be adding. So in essence, although there's been a wide range report in the literature with a median rate of around 5% in meta-analyses, you're still looking at a very comparable rate of spinal cord injury in the endovascular era compared to our open series. Some people have looked at the risk factors, and normally this is a univariate analysis on the left. You would think, okay, so certain things like age, comorbidities like C8 coronary disease, COPD, peripheral arteries should be relevant. But in fact, in their univariate analysis, did not have any difference between those patients who had spinal cord injury and those who did not. Previous TVAR did in their univariate analysis. And again, I mentioned because you're covering collaterals, you may be more prone to developing spinal cord injury with those. The zone of coverage, how much you cover the aorta, obviously, and with the extent too being the particularly liable ones for spinal cord injury was significant. The use of catecholamines, why is that? Probably because you had hemodynamic lability in the OR, and that's what it was indicative of, that they added catecholamines. Ended up being a risk factor, and then of course zone of coverage down below. The only thing that factored out in this particular series in the multivariate model, however, was zone of coverage. Everything else fell out, and the only thing that was significant was how much of the aorta covered. 100% indicative of something coming from the subclavian down to the bifurcation was associated logically with the biggest predictive risk. So again, in this series, 142 patients, 16% had spinal cord injury, roughly divided between full paraplegia and paraparesis. The interesting thing is less than half showed the deficit right at the time of surgery, and slightly greater than half went on to evolve over the ensuing 48 hours. And the also notable thing is that a great majority of their patients actually went on to recover and had no irreversible paraplegia at the time of discharge. So this is the new endovascular era and what we're dealing with in spinal cord injury patients. So what are our protective measures that we're using? I must say there's a dearth of level A data based on prospective randomized trials that are driving a lot of this, but there are some common sense things, and then there's institutional preferences. I put little asterisks around things that are considered somewhat controversial. Heparin dosing I don't think is controversial. Most of us will anticoagulate these patients to prevent thrombus formation. Moderate hypothermia is generally a good thing, and how you do that in the setting of endovascular, whether it's with cooling blankets. Obviously, you don't have a pump to drive to lower the core temps, but you can use cooling blankets and cooled IV fluids, maintaining a good, little bit of permissive hypertension, so to speak, a good perfusion map. Now, CSF drainage, like I said, is on the other side of the spectrum, and you want to lower it, perhaps to a 10 millimeter mercury gradient to allow better perfusion of the spinal cord. The concept of somatosensory evoked potentials to see if you can capture any sort of spinal cord injury real time. But again, that might be ameliorated now in the era where a lot of these are occurring in a delayed fashion. You would think that this would not be as effective in that scenario. I'll briefly allude to this temporary aneurysm sac perfusion concept that's coming down the line with these fenestrated graft usage, and then the pharmacology of this, whether you believe in barbiturates, steroids, or mannitol, is a matter of individual preference, in my opinion. There hasn't been a lot shown in indisputable data. In the postoperative setting, now in just contrasting to the intraoperative period, on ICU monitoring, more for, I think, neural monitoring than necessarily hemodynamic, maintaining the same perfusion pressures that we were attempting to keep during the procedure, and then plus minus CSF drainage. So again, just to recap on a couple of these concepts, CSF drainage, like I said, there's somewhat of a paucity of data. There were 3 large randomized trials in open repair, 2 of which showed a benefit and 1 that revealed no effect. There haven't been any, to my knowledge, of randomized trials in the TVAR era that have looked at this issue head on. We all have anecdotal sort of experience where we had a delayed or latent spinal cord issue present itself that subsequently recovered with placement of a CSF drain. There is an incidence of intracranial hypotension that sort of makes it hard to just globally use for many individuals, however. The idea of temporary aneurysmal sac perfusion is, so think of these fenestrated grafts, it kind of goes against the whole concept of why we're trying to close these. The idea of having a ongoing perfusion of your aneurysm sac after endovascular repair is sort of abhorrent in our field, and yet that's exactly what this is attempting to do. You're staging your repair such that you're causing proximal and distal seals, but you're still perfusing the aneurysm sac and therefore the vital intercostal vessels, etc., through an open branch, which you then go on and either close or establish continuity later at a later time. So one of the larger series I found with this was about an evenly divided group of 83 patients, roughly half had this concept, half did not. And they showed a pretty remarkable reduction in spinal cord injury in the temporary sac perfusion group versus the non. I must say this is a little bit high, so I don't know, exactly how this particular study would justify this, but they did show a significant difference in their series. Their median days to going in and closing this perfusion side branch was 48 days, and they did have 1 death associated, in my opinion, with what would have been a complication of this very thing. You still have aneurysm sac perfusion, pressurization, and therefore there is some risk inherent to that, whether it's rupture or, in this case, aortobronchial fistula. So just to conclude, I think TVAR, this is one of the questions that I presented in the handout. The TVAR did not necessarily bring with it a new era of lower spinal cord injury. We still have to be very cautious with this concept. And that level A data, really good, multiple prospective randomized trials looking at a lot of the things that we do place are somewhat lacking. I think we have institutional and personal preferences. We also use subclavian CSF drainage pretty much universally in these patients. But again, I think these are somewhat institutional based, and you can find some surgeons who refute that very notion as well. As in open repair, the endovascular patient, the trends lean towards delayed presentation. So our scrutiny has to extend beyond the original intraoperative approach to the postoperative as well, and we can't let our guard down at all during these cases, during their hospital courses, because it can present at any time. Thank you.